It's a pleasure to be here today. I am here to talk to you about drug abuse and addiction, the current status of where we are, and future directions for the Department of Psychiatry and Behavioral Medicine. The first thing I want to talk about, of course, is disclosures. We don't have any yet. And then we're going to talk a little bit about sort of the basics, where we are now nationally, at the state level and locally. For us locally, some of the underlying social issues. Many of you know that I was the director of emergency psychiatry for about a decade, a while back. And so the social issues that impact our emergency room are very relevant to this presentation. And then future directions for our department and our med school in terms of education, research, and patient care. The basics, of course, because we have a mixed group here. We have some resident applicants with us. We have med students. We have residents, and faculty, of course, and social workers, nurses. We have a broad spectrum of folks that are here to learn today. So we want to start with some of the basics. So let's do that. What is a drug? I will pick somebody out. All right, crickets. I could actually play a song about crickets if you want.
So a drug would be any chemical that you take, pretty much.
Yep. Does it have to be a chemical?
No. Well, I would think so. It has to be an element of this.
What about gambling? What about gambling? So there's not a good answer to this, but yeah, what is a drug? I mean, does it have to be a drug? Does it have to be a chemical? Does it have to be a compound? So we'll talk about that, but I wanted to start you thinking, okay? This, in my opinion, is one of the world's most common drugs, right here. All right? Everybody in this room has one, I can guarantee you. If you don't, you are an outlier and a stranger in a strange land, because this is one of the world's most common drugs, and it's information, in my opinion. In 2003, I took my family to Disney World, right? We had a great time. 5 years later, in 2007, I went back. You know what happened between those 5 years? The advent of the smartphone, okay? It was kind of sort of there in 2003, but in 2007, it was prevalent. People were no longer looking at Mickey and Minnie and Donald Duck, or is he Disney? Yeah, he's Disney. Isn't he? Yeah. They were looking at their smartphones to see when their ride was going to be ready, because there were already 100 apps out for Disney at that time. Okay, everybody was looking down, walking around like this. And that's how we live our lives today. This is the world's most common drug. At least that's my problem with the world today, is that we need an EMP grenade the size of California. But then I wouldn't be able to present to you except on paper. So what is a drug? Any substance that affects our bodies or mind. It need not be a medicine or be illegal. It causes changes in behavior, emotion, or thought. It may result in intoxication, which literally means poisoning. It is now known that some changes can be permanent or long-lasting. If any of you have learned to ride a bike, you can't unlearn that. And so if you use a drug, oftentimes your brain learns how to use that drug, and it's permanent. And so it can cause some permanent changes in brain structure or function, and can significantly impact cognition. We were talking earlier today with one of my resident applicants about the fact that, synthetic cannabis, just using once, can induce psychosis permanently. And it doesn't have to be synthetic, but it's even worse than the natural stuff. I'm not sure why this is going backwards, but it is. Let's try this. All right. Substance-related and addictive disorders in DSM-5 does not include behavioral disorders such as internet gaming, shopping, or exercise addictions or sex addictions. It does include information, does not include information, but it does include gambling use disorder. Okay, and so our DSM-5 is a very interesting way of looking at psychiatric disorders. As you know, we went towards what's called a spectrum of disorders. And so what we used to call drug abuse and drug addiction in DSM-4, we now call substance use disorder mild all the way up to severe. And that categorization is based on some things that, this is alcohol. I've taken out alcohol, the word alcohol, just to make it generic. But this is a substance use disorder classification for DSM-5. So a problematic pattern of use over a year causes clinically significant impairment or distress, which, as you know or may not know, if you're still thinking about becoming a psychiatrist, anything in the DSM-5 has to cause clinically significant impairment or distress. It has to impact your life, your world, something. It has to cause problems for it to be a problem. If it's not causing problems, is it a problem? That's a good question. And that's why I think that cell phones are dangerous. But anyway, at least two of the following: using more or longer than intended, desire to quit, attempt to cut down, loss of time spent obtaining, using, or recovering, craving use of the substance. So just as a thought experiment right now, think about how you would feel if you pulled your cell phone out and turned it off. Does that evoke a sense of anxiety? For me it does. Yeah, for me it does. Turn your cell phone off. Leave it off for a day. Think about that. Now, we have been raising children for millennia. But why do you want to leave your cell phone on? I know why. Because I have two kids. One of them called me yesterday. I might miss it, right? We've only had phones for 100 years. We'll be okay. But that's the kind of thing that they have brought us to the point of. The more we're connected with these, the less we are connected individually and humanly, personally. So, continued use despite persistent life problems, life activities given up because of use, continued use in dangerous situations, texting and driving, continued use despite knowledge of the problem, tolerance to higher doses, withdrawal when not using. Now, so when we're looking at this, we're talking about, for example, alcohol or amphetamines. I'm using cell phones as sort of my own personal example, but alcohol, this can cause significant issues. Amphetamines, marijuana, whatever you want to put in here as the drug, this is how we categorize it. So, very interestingly, about 2 years ago, Louisiana revised their revised statutes. They're called revised statutes because they get revised a lot. And if y'all, as psychiatrists, have not read Louisiana revised statutes, you should. Section 28 at least, because that is the section of mental health code that governs how we practice medicine. It's incredibly boring. It will help you sleep well at night, but you really need to use it, to read it, to see what it says. And in Title 28, definitions, behavioral health is a term used to refer to both mental health and substance use. So back in the day, for 20, 30 years, I would say, we have not treated substance use disorders here, as they're called now, because we were not, quote, licensed, unquote, to do that. Well, it's different now. So in section 21.1b, substance-related and addictive disorders, this language has been added and updated. The purpose of this section is to recognize substance-related and addictive disorders as a sickness or disease and to place those suffering from it in the same position relative to obtaining treatment as persons suffering from other diseases. In other words, they are no longer separate. They are no longer apart. They are no longer different. They are no longer just a social disease. They are now actually medically ill. We can treat them. More importantly to us, Medicaid now pays for it. That is very important because Medicaid will pay for the treatment and the medications. So, with that, those changes in the law were just recently. I think that was 2017. And many people, unless you go out and read the law like I did, don't know this. It's not something that has been trumpeted from the rooftops. It has not been something that has been talked about in the news very much. At least I wasn't really aware of it until I went out and read that and talked to some folks. So let's move to looking at some of the statistics. What does it look like in our country, and what does it look like in our state, and what does it look like in our area locally in terms of substance use disorders? And so this is from SAMHSA, Substance Abuse and Mental Health. What does the last essay stand for? SAMHSA.gov. I can't remember exactly what it stands for. Someone Google that on their phone that you're addicted to and tell me what the answer is. But this is from 2018, so it's recent. So 60% of the U.S. over 12 years old use substances in the past month. Now, when you think about that, okay, well, that includes alcohol, that includes cigarettes, that includes cannabis. So a lot of that, you know, okay, fine, right? 51% drank alcohol, 31% binge or heavy drinking. That's 84 million people in America. 22% used tobacco and 12% used illicit drugs. In the past year, because that's just in the past month, in the past year, though, almost a fifth of our population, almost over 50 million people, used illicit drugs. That's a lot of people, y'all. When you break it down, you can see that quite a bit of it is marijuana, and then prescription pain reliever misuse. And so many of you may be aware that we are in the midst of what's called the opioid crisis in our country. If you look at the CDC's life expectancy graphs over time, you know, back in the 30s and 40s it was low, and then over the years it's gone up. And it's been fairly stable with a few variations, but in the past few years there's been a dip, a decrease, a lowering of life expectancy. And that decrease has been due to one thing, and one thing only, the opioid crisis. People are dying from taking so many opiates and overdosing on them and dying. And so there's a little dip there, and we're trying to get that little dip to go away and improve our life expectancy. So pain reliever misuse and even street drug. I mean, there's a fentanyl crisis. It's not as bad here, but heroin is a big problem in New Orleans, and fentanyl nationwide. It's apparently being able to be made and synthesized. They're not stealing it from pharmacies, but someone's making it. It's incredibly powerful. One tiny little fragment of it, like I don't even know how to say a pinhead's worth of the powder, of the pure stuff, can kill you. That's how powerful it is. And then we go on to hallucinogens, cocaine, stimulant misuse, inhalants, methamphetamine, and heroin. And this is nationwide, so every area is different. Again, New Orleans has a lot of heroin. We don't have hardly any. I've only seen a few cases in the 20 years I've been here. But what we do have is a huge methamphetamine problem. Huge. So this is nationwide. Now this is illicit drug use by state in the past month. This is 12 or older. And Louisiana, what I wanted to point out is that we're 9 to 10%, but we're kind of like in the middle of the pack across the country. Other states are worse. Other states are better. Texas is better. You know, Colorado's worse. This is illegal drug use other than marijuana in the past month, 12 or older. And Louisiana, again, it's not in the middle anymore. We're kind of towards the top. We're about 3.5% of our population is using illegal drugs other than marijuana in the past month. So, okay, what about this one? This one's kind of interesting. This is marijuana use in the past months. Look carefully at Colorado. You'll see it's a little bit different than the other states. Why is that? Access. That's exactly right. If you're looking carefully at that, you can see sort of a background there that is pertinent. That is Cheech and Chong, for those of you who don't know who that is. So Louisiana's going to look like that soon, okay? Louisiana is legalizing marijuana for medicinal use. I would predict that within a decade after that, they're going to legalize it for for recreational use. Why? Because they can make money off of it. Because we're, in the flow. We're one of those states that has done so out of, I think it's now 25 states. How many states? Does anybody know? I should know that. Someone can Google that too. How many states now have legalized marijuana? In any case, Louisiana is probably going to be red soon instead of blue. And so we are at second from the bottom, 5%, and I predict that we will be probably higher, much higher than that within a few years. So keep that in mind. We have been asked as a university through Dr. Ghali and from him through the state, Louisiana Department of Health, to create a database for outcomes on the medicinal use of marijuana. In other words, the adverse outcomes, okay? So some of my talented residents have worked on that, and we're actually going to expand that to include the adverse effects of the synthetics, because we have a bigger problem with the synthetics right now than we do the natural stuff. But the importance of that is that we're going to have more marijuana use, and so we can then track it, as to what the side effects are. We kind of know what the side effects are. For psychiatrists, the big one is what? Psychosis. We've already talked about that. It can be pretty bad. Okay, so moving from, looked at the federal level, we've kind of looked at the state level. Now I want you to look locally at what our use population looks like. And so this is another project that my residents are helping me work on. This was data that we collected in the past from our emergency service, psychiatry emergency service, and we are soon to publish. The psychosocial factors that walk into our emergency room as patients are often more prevalent and important for us than the actual underlying psychiatric disorders. They walk in depressed and suicidal, but they're not necessarily suicidal because they have a neurobiologic illness. They're suicidal because they're homeless, they've been abused, they come from a broken family, they've been violent to others or had violence done to them, they're in trouble with the law, and so all of these things contribute. One of the biggest contributing factors is substance use. As you can see, when this was like 160 people that walked in, randomly chosen, 80 males, 80 females. 90% of the males were using some kind of substance. A lot of that is cannabis, but still, a lot of it is not. A lot of it is worse. And then about 65% of the females were. So this is what we do on a daily basis. This is what Dr. Booker does in the crisis unit, is take care of these patients. The problem is that up until recently, we haven't really done much in terms of substance use disorder treatment. We detox. We do that every day. We're good at that. But what do we do long term? What do we do after detox? Is detoxing alone going to get somebody off of the drugs that they're on? The probability is limited, low, that will work by itself. They will tell you, I don't want to use, and they will leave, and they will use, unless they get into a substance abuse rehab program. We do a whole lot of referrals to rehab programs, don't we, Beth Allen? We do. How many of them go? Well, we want them all to go, but the recidivism rate is significant, very significant. Okay? And so we need to do a better job of taking care of these disorders, and we're working towards that. So the psychosocial factors are important, and so it's important to realize that these are individual psychosocial factors. But someone doesn't just walk in coming from a broken family. I mean, my parents were divorced. I'm on my second marriage. Broken family doesn't necessarily make you a drug addict in the ER. Being abused doesn't necessarily either. It's a huge factor, though, especially in females. But the fact is that they don't walk in with one of these. They most often walk in with 3 of these problems, or 4 of these problems, or 5 of these psychosocial issues. They walk in as a very complex social problem for our social workers to deal with. And we, as psychiatrists, we just have to keep them alive, medicate them, detox them, and hope that our case managers can find some place for them to go. And so, in a recent White article I wrote, I told the leadership that if you guys have an option to hire a psychiatrist or another case manager, you need to hire a case manager, because we need more help in the ER, because the psychiatry part we got. The social part, that's huge. It's really bad. It's really big. So we're working on that. And this is another reason why we need more of that. So starting back in, I think about 2005, 2004 is when I started doing, no, it was 2002 or 3. It was 10 years of emergency psychiatry. But we have data going back before that as for how many patients we were seeing per day. And so we collected data all the way up to 2011, 2012. And as you can see, the annual new patient visits to the ER continues to increase, and it's still going up. The interesting fact is that our population in Shreveport is not increasing. It's actually gone down a little bit. So it's not more people. It's more people that are sick and presenting to the ER out of the existing population. Very interesting. Why is that? It's another question for another day. But one of the big things we do see is this, the dual diagnosis population. In fact, I would say that, rarely do we see someone walk in with just a substance use disorder. We see a whole lot of SUD plus something else. For some reason, schizophrenic patients and schizoaffective disorder patients tend to like crystal meth and or cocaine or both, and marijuana. I mean, you ask them you'll ask them if they use drugs. No. And then their drug screen comes back positive for marijuana. Well, that's not a drug. That's like drinking. That's nothing. I'm not using any hard stuff. I'm not using meth. So this is nationwide, again, 2018, adults with a substance use disorder and a mental illness, 9.5 million, or 9.2 million, 9.25, and adults with a serious mental illness, SMI. So that's things like schizophrenia, bipolar, schizoaffective disorder, depression with psychosis, things of that nature. So 3 million people. So these numbers are significant. These numbers are the patients that we are often faced with on the 10th floor and in the crisis unit. Not so much in our outpatient clinics. Do you know why? Because our outpatient clinics have, until recently, not taken patients with substance use disorders. We've changed that. We now take referrals for patients with substance use disorders. And we are expecting that we will be able to help these patients get better by making sure that we do everything we can to treat not just their underlying psychiatric disorder, but their underlying substance use disorder. The reason is because you can't treat schizophrenia or any other disorder if the discharge plan is a crack house. And so when we send people out that are homeless, where are they going to go? They're going to come back to the ER. That's where they're going to go eventually if we send them out to a place like this. And so I've been working with Ochsner and Oceans to try and meet with some of our community partners to develop a better plan of care, a better way of dealing with these patients, a better workflow to move patients where they need to be, to have the care available that they need. Because right now, we're kind of stuck. We have patients that are waiting on a bed in Central. There's a 2-year waiting list at Central. We have a patient that's waiting to get into Rusk. A long wait. Rusk is in Texas, by the way, so that's another state hospital system. And what happens when we send them there? I trained at the University of Texas Medical Branch. We used to send patients to Austin State Hospital all the time. We'd hold them for months waiting to get them in there. We'd finally get them in bed. 2 weeks later, they would be back. 2 weeks. Why? Because Austin discharged them. So we need to find a better way of caring for patients than putting them in an institution. And there are ways that exist. We just have to implement them. We have to, the assertive community treatment teams can help. In my opinion, they're not assertive enough. If you're going to call yourself assertive, y'all need to be out there in the streets. So, how do you treat substance use disorders? How do you treat SUD? Well, the very first thing you do is learn how to treat SUDs. If you don't know how, learn about treatment for SUDs. Start accepting referrals for patients with SUD, because you can't treat them if they're not coming to you. You have to have patients that want help. And then you have to inquire. We had a patient that I was covering on the 10th floor on Dr. Silverblatt's team that I was like, no one had talked to him about treating a substance use disorder. He'd been there a day, so Nancy hadn't seen him yet. Do you want to get better? Yeah. Do you want to be an addict? No, I want to get better. I want to stop using. Well, that is a new way of thinking for us. We're used to treating the depression. We're used to treating the anxiety. We're used to treating the psychosis. But unless you treat the substance use disorder, are they going, and you ask the patients, they will tell you straight up, if I start using, I'm going to stop taking my medicines. I don't want to have a drug interaction. Really? So you're okay with smoking crack, but you're not okay with your taking your Prozac. There's a problem there. It really is. So I've actually told them, if you're going to use, don't stop taking your medicine. It's going to make you sicker. But try not to use. But then actually treat the substance use disorder. And this is my request from y'all. Start treating substance use disorders. Start in the inpatient unit. Start in the outpatient clinics. Start in the ER. Start wherever. We don't have a lot of psychotherapy yet. We need more psychotherapists. We're going to be presenting data later today in the Behavioral Health Service Line meeting, or our meeting with the hospital, to talk about how much we need more therapists. They're very important. But for the pharmacotherapy side, I know a little bit about that. And yeah.
When you start treating, are you saying Suboxone, Naltrexone, buprenorphine, is that going to be available in the outpatient?
Eventually, yes, it is. Naltrexone is available today. You can prescribe it. It's non-formulary inpatient, but you can still order it. I actually called the pharmacist and said, I want to order Naltrexone on this patient. No one's ever done that before. We don't have that. It's non-formulary. Can you get it? Yeah. So we actually got it, I think. Did we start those patients on those yet? My residents, yeah? Yeah, so we did. And we also found out, I sent an email out yesterday, one of our case managers called Medicaid and asked, you can get Naltrexone prescribed for amphetamine addiction. It's not indicated. It's indicated for two things, alcohol and opiate. Okay? But you can use it for crystal meth. And as I'll show you in a minute, it works. Okay, so I want to talk a little bit about our new center, because education is one of the things that we really need to do. And so the Louisiana Addiction Research Center was a new center proposal that we submitted just recently with the help of a lot of people. Dr. Nick Getters is the lead for that group, and I'm on board with that, as are many others. It's really a multidisciplinary team of basic and clinical scientists that are moving forward with our endeavors to do more for addiction. That includes Donnard, that includes Dr. Hugh Nam, and I don't want to miss folks. I know there's some more out there, but it's an important endeavor. This is not an approved center. We want y'all to know it's a proposed center. And so it just went to the Board of Supervisors, I think, this week. And from there, it should go to the Board of Regents soon. But it's important. In this graphic, thank you, Donnard, for creating this wonderful graphic, shows all the different ways that we want to interrupt the cycle of addiction, whether it's at genetics. whether it's at the social level, whether it's through clinical trials, any of these different ways, because it's tough to stop someone from using drugs. It's tough. It's not easy. That's why it's such a bad problem. And that's why we have to attack this problem from multiple different places on the circle, that we have to stop people from using and figuring out why they're using at the genetic level, why they're using at the environmental level. So this is the objectives for LARC. So to identify and establish models of care, this is one of the things I was talking about recently, that we're not really doing all we need to. Right now we have an acute model of care. We detox. That's about it. We refer to rehab, but we do not have an IOP, an intensive outpatient program, which is desperately needed. We don't have, and we're not using any medications for treating substance use disorders, and we need that. We need to educate and train providers on how to do that. We are working with the North Louisiana Crime Lab to identify illicit drugs, specifically the substance called Mojo. We know probably that it's a synthetic endocannabinoid. We don't know which one. If you go and look online at the list of possible synthetic endocannabinoids, there's over 100 of them. 100, just for the endocannabinoids. If you go to the Wikipedia and look up list of synthetic designer drugs, there's thousands of them. Back in the day when I was a kid, we had LSD, and then X came along. All right, that's all there was. Now, thousands of them. Endocathinones, the cathinones are really, that's the bath salts, really nasty stuff. So the stuff, we sent him a couple of samples already. One guy said he was using Mojo, but his screen came back positive for marijuana, amphetamines, and cocaine. Okay, so he was using, they told him it was Mojo, but they probably sprinkled some amphetamine on a marijuana cigarette and told him it was Mojo, because what did he want? He wanted to buy Mojo. So he goes to the drug dealer. Drug dealers are not FDA approved, y'all. Okay? They don't have to sell, they don't have material safety data sheets for their product, okay? And so you don't know what you're getting. Developing treatment modalities through clinical trials, we'll talk about that in just a minute. Brain structure and function relationships, y'all know I love brain imaging, and so we're definitely going to be looking at that. Genetics, animal models, Dr. Naum, looking at alcohol and genetics now. Donald, looking at a study involving genetics, or helping with that. And then working with the looking at cardiovascular health with the CCDS. That is one of our centers for cardiac health here, that we've recently discovered that crystal meth is, besides being one of the world's most dangerous drugs, it causes horrible cardiac problems, cardiac and fibrosis and scarring in heart tissue. And so there are very few drugs actually that are good for the heart. It's just that crystal meth happens to be particularly bad for the heart. And so we're looking at ways to combat that. So here are some of the medications, the drugs of use, not abuse, that we can use to treat substance use disorders. And so it's, it's not a short list. It's actually a significantly long list. Naltrexone and its long-acting injectable form, Vivitrol. Varenicline, used for smoking cessation. Bupropion. How many of you prescribe bupropion on a daily basis almost? Yeah? Have you ever talked to your patients whether it helps for anything other than nicotine? It does. It absolutely does. It decreases craving. It does help. Is it a magic bullet? No, it's not. None of these are. Topiramate, acamprosate, buprenorphine, repetitive transcranial magnetic stimulation, and others types of brain activity interventional type things. This is a very exciting area. We have two guys in town, but neither one of them work here that do RTMS. And I doubt that RTMS is indicated, I know it's not indicated, to treat substance use disorders, so it would be a cash-only basis. Disulfiram, which is antabuse, that's the one that makes you sick if you drink when you're taking it. Modafinil, that's an alertness medication. Gabapentin, something that we use for all kinds of things. Anxiety, seizures, augmenting the treatment of bipolar, neuropathy. Vigabatrin, baclofen, and even mirtazapine. Believe it or not, go out and Google mirtazapine and addiction. It actually has some clinical efficacy. So the medications are out there. It's possible. We just have to start looking at which ones to use for what. And so let's talk about naltrexone for a minute. I want to focus on this one because, one, it's available, two, it's indicated, and three, it works for other stuff. Yes? Yeah, we had someone snorting gabapentin the other day. Seroquel has street value. You do your best. There's not a magic answer to that question. You just do your best. Obviously, snorting gabapentin is going to be better for you than snorting heroin. I don't know that it's going to, it might hurt your nasal passages, but you can take a buttload of gabapentin. It's not really going to do anything. It's just going to get excreted. So it's not good for you. It's obviously problematic, but, that's one of the things. If you look in the literature and you look at the model of care involving buprenorphine, you're trading one drug for another. You're improving health, you're improving outcome, you're improving their ability to function in society by trading an illicit drug of abuse with a medicine that's prescribed and controlled. That still has street value. That's buprenorphine. And so that gets them back into society, though. So you're not curing their addiction. You're just treating the illness and making them more functional. And that's part of the different model of care. When I was growing up and when I was in training, it's like, no, you just need to stop. Stop using. That's the answer. We're not going to give you any pills. We're not going to do anything. You need to stop using. Well, that doesn't work. It doesn't work, period. It's not helpful. What you want to do is decrease use. What you want to do is best you can to get them to use less, to have less morbidity, less mortality, to improve the quality of life. So naltrexone, it's indicated for alcohol and opiate use disorders. It works for other things, but it's not indicated. That includes meth. I'm going to show you that in a minute. It has two formulations, oral and long-acting injectable. You prescribe it once a day with food for 12 weeks. You can go up to 100 or even 150, depending on the patient. If you look at the package insert, you can individualize that to meet the patient's needs. How long are you going to treat? 3 months to a year is what the indicated amount is. But it really depends on the patient there. Does cause some side effects, GI side effects, and if you think about the mechanism, what do opiates do if you take a lot of them? Clogs you up, stops you up, causes constipation. So if you take an opiate antagonist, yeah, so you start low and go slow so they don't get too bad, cramping and diarrhea. And do not put them on this if they are detoxing from opiates. What's going to happen if you do that? They're going to be... You can do that if they are anesthetized. There's an ultra-rapid detox protocol out there that our new provost coming on board likes to do and wants to implement. It rapidly detoxes them off of opiates, but you have to be under a doctor's care in the hospital and more or less knocked out while they reset your receptors in the brain. Because it's pretty bad. If you do it when you're awake, it's painful. So also, what's going to happen if you, in the crisis unit, if you give someone a prescription for naltrexone and say, here, take these and come back in a month? They're going to stop? No, they're not. Which they don't fill many of the medicines we write in the PCU. But we still try, right? We still try. And so that's what we have to start doing. Because if they really want to, maybe 10, 15, 20% of them will get it filled, and the other 10% of them will take it. And some of those will actually get into treatment. But if we don't try, where are we? So how does it work? Well, naltrexone is an antagonist at the mu and kappa opioid receptors, and so it attenuates the effects of opioids that way. But that's an opioid use disorder, OUD. An alcohol use disorder, how does it work? Well, this was kind of a mystery at first, but then it was discovered that these opioid receptors have a natural endogenous peptide that works at them. They're not just there for our Lortab and morphine to work at. They're there for natural reasons, and the natural endogenous opioid peptide is called dynorphin. And so that is implicated in not just alcohol use disorders, but other use disorders. Is naltrexone safe? So the thing I've always heard about is, well, you got to be careful with the liver. That's because it's used in alcohol, and alcohol causes problems with the liver. And so if you have liver failure in a patient, you do need to be really careful with this drug. Okay? But if they're not in liver failure, that's not a huge problem. So this is a meta-analysis that looked at over 11,000 patients from 89 trials. It does not appear to increase the risk of serious adverse events over placebo. That's pretty good. That's pretty strong data right there. So I think it's pretty safe. You do obviously have to be careful with the fact that it's liver metabolized. Topamax, topiramate. This is one of our drugs that we use for a lot of stuff. It's one that doesn't cause weight loss, or pardon me, doesn't cause weight gain, rather. Important distinction there, because many of our drugs do. And so because of that, it's fairly, common, popular. It is indicated for alcohol use disorder. You can start at 25 milligrams a day and titrate up slowly, maximum of 300 milligrams a day in divided dosages. And there have been several randomized trials that have shown improvements in measure of alcohol use. Naltrexone and topiramate, I want y'all to understand, these are not magic bullets. You prescribe them, you get them on them. If they stay in a treatment program, it increases their chances of sobriety, it decreases use, it improves outcomes. It's not a cure, it's not a magic bullet, but they help, okay? And so they should be used as a part of a comprehensive treatment program. Now, unlike naltrexone, topiramate has sort of a long list of possible side effects. It's kind of a nasty drug when you look at it. It can cause kidney stones, changes in cognition, and so you really have to look at the risk versus benefits with this medication, okay? If they really need something, that, especially if they have a seizure disorder or something else that Topamax is indicated for or used for, you might want to consider it. But if they've already had kidney stones that have wiped out one kidney, I had a patient like that once, and a doctor prescribed Topamax for her, and I said, oh no, you're not taking that. Because it can definitely cause kidney stones to the point that, if you're already predisposed to develop kidney stones, they can be pretty nasty. So you got to be careful of that. Polypharmacy. In general, we try and stay away from that. But when you have more than one drug that has a different mechanism of action, and each drug doesn't really work great, it has sort of a mild to moderate effect, then you might want to consider using two together, okay, that have a different mechanism of action. And again, a pill alone is not going to work without a treatment plan, but if you have two pills with different mechanisms in a treatment plan, they might work better, all right? So keep that in mind. If your patient is covered by Medicaid, which many of our patients here are, then using off-label and not indicated, you need to make sure that they can actually get that medicine filled and off-label. Sometimes you can. It depends on the medication. And apparently, and this is an N of one phone call to one Medicaid company said they would cover naltrexone for amphetamine use disorder, even though it's not indicated. So that's one Medicaid company. The other 4 or 5 in Louisiana may not. And that was one phone call to one person. So I'm really interested in my residents in the outpatient setting, or even in the ER, trying to get this indicated to see if we can get that waived, or whether it works, whether it's covered. All right, so research on the treatment of methamphetamine use disorder. If you look in the literature, there's quite a few things that have been tried and many things that work. One of the naltrexone studies that didn't work was one that used a long-acting injectable. And I think they didn't find significance on that because they were looking at, it's the way they looked at it, okay? Now, I don't have a lot of time, but there's some negative studies out there. I'm showing you the positive ones here. 3 studies have shown an improvement in outcomes in amphetamine use disorder with naltrexone. 2 with buprenorphine, and again, we don't have a medication assistance therapy clinic here. It would be nice if we did. But that's a model of care that you're trading one drug for another. In this case, buprenorphine for amphetamines. Does it work? Apparently. Do we want to do that? Maybe. But right now we have naltrexone. RTMS works. We don't have that. Topiramate works. We do have that. 1 study. So the dopamine receptor, the D3R receptor, one thing that all drugs of abuse share, including gambling, including shopping, including phone use, is the ability to elevate dopamine. And it elevates it in the part of the brain called the ventral striatum, which is the accumbens, and the shell part of that nucleus. And so the D3 receptor is concentrated there. It's associated with this part of the brain, right? And so if you activate that receptor and you release dopamine there, it increases reward, it increases the good feeling. That's what dopamine release is all about. That's why you take drugs to release dopamine. Gambling does it, amphetamines do it, heroin does it. And so if you can modulate that receptor, you can modulate the reward processing and the motivation to use that is involved in drug seeking, right? Maybe. So what drugs have strong D3R binding? Right now, there's a few, but the one that's on the market is Vraylar, cariprazine. I know. Why? Because it's new and expensive. But so I do a lecture on binding profiles, and I've had to modify my graphs twice now. Once for acinapine, which I'm not showing you, but the other one for Vraylar. And so right here, Vraylar, the lower number is a higher affinity, right? So the higher the bars go, the tighter the affinity of the drug for the receptor. And so that doesn't necessarily mean it's more powerful. It doesn't mean it releases more, but it binds tighter, okay? And so I had to modify the scale because this one went over 0.1. It's 0.084 nanomolar. It's incredibly tight binding. What does that mean? Well, it's a D3 preferring antipsychotic psychotropic agent. So it is an antipsychotic. It's indicated for schizophrenia and bipolar. But with this kind of differential right here, it may work for substance use disorders. We don't know yet. There's been a few studies out there that are looking at it. And what I want to do is a clinical trial to look at naltrexone versus cariprazine versus the combination. The hypothesis being that combination therapy will be more effective. The problems we would expect for this kind of study is dropout. Our patients are not exactly the most reliable, especially when they're using drugs. So it's one of the things. All right, so in summary, don't ignore substance use disorders, okay? Treat them. Try to get them on something to help. They're going to fail, they're going to relapse, but currently we're doing nothing long term. We are detoxing them, that's good. We want to keep doing that. But we want to make sure that they stay sober to the best of our ability to do so, or use less to get part of their life back, right? So doing something is better than doing nothing. And some patients will succeed if we do something for everyone. Okay? Thank y'all very much. Have y'all got any questions? Some of the AA groups are very much anti-medication, yes. And so I would recommend that if you refer someone to AA, that you talk to them about that and say, look, make sure that you know what you're walking into, because that is a philosophy that I disagree with, and that you as physicians may want to carefully consider before you send them to AA or any place. because that is a thought. Yes.
I just wanted to point out, at least 1/3 of them, we do try aggressively to get them to these substance abuse. So we go beyond detoxing. But if they're not interested,
They're not.
don't bother.
I know. And so when I say we need to go above and beyond, what I mean is we need to develop our own program here. And so we need an IOP. We need therapists. Those are the two big things we need right now that I keep pushing. We need therapists. We need an IOP. Yes, Mary Jo.
A lot of times we do get the
Yep.
and I worry about the ones who just leave and not go. Some of them are
Yep. They do. And so, even with a clinical trial, my preliminary draft of this is that the dropout rate is probably going to be 60, 70%. They don't stay. That the methamphetamine is one of the most addictive drugs in the world. Okay? It pulls people out of sobriety and pulls them into use in a horrible way. And so it's very nasty. It's very nasty. And so that's why I want to get Naltrexone into them as soon as I can. Is it a magic bullet? No. But it decreases craving. And so it might give them that edge to stay sober for another week, another month. Any other questions? Yes, ma'am. Due to crystal meth and drugs like that? Yes. Yes, absolutely. And it's hard to say because again, none of these street drugs are FDA approved, so you don't know what you're getting. The first one we tested had something in there called MCCP, which is an agent that they use to cut that's really nasty, that can be neurotoxic. They don't care. But I can't recall exactly what it does in terms of long-term damage. Ecstasy has always been known to cause that. That's why they always tell you to drink a lot of water with it, is methylene dioxymethamphetamine is neurotoxic at, I think it's serotonergic neurons. Yeah. Any other questions? Thank y'all very much.